Hi there, my name is Dr. Tushar Menon, and I am a second year internal medicine resident at Brazo. And I'll be here today presenting a case report on anterior tibial artery pseudoaneurysm with post endovascular arthrectomy and revascularization. So, pseudoaneurysms are false aneurysms that are caused by injury to the arterial wall, resulting in locally contained hematomas with turbulent blood flow. Pseudoaneurysms are usually secondary to trauma or iatrogenic injury, especially after surgical procedures, while true aneurysms are a result of infections, inflammatory processes, or congenital conditions. Anterior tibial artery pseudoaneurysms are extremely rare, with very few cases reported in the literature. Our patient is a 63-year-old male who had presented to the ED from an outpatient vascular lab due to an iatrogenic aneurysm, status post left anterior tibial artery arthrectomy and revascularization. Prior to the outpatient procedure, the left anterior tibial artery showed a 70 to 75% stenosis proximally and occlusion distally. The left perineal artery was 100% occluded proximally, and the left posterior tibial artery was 100% occluded. The patient underwent a turbohawk arthrectomy, and post-arthrectomy, in the intravascular ultrasound, it revealed a 5 by 8 millimeter aneurysmal dilation. Immediate covered stent was introduced to repair the aneurysmal dilation due to the injury to the intimal and medial layer. However, it could not be positioned in the optimum location due to tracking issues. The procedure was terminated after final angiography revealed patency of the left anterior tibial artery proximally and still good flow via the collaterals into the perineal artery. Due to the size and pulsatile nature and instability of the aneurysmal dilation, the patient was transferred to the hospital. The next day, the patient had a bilateral extremity arterial Doppler ultrasound, which revealed a left mid-superficial femoral artery with 50% stenosis and an increased velocity, minimal flow to the left dorsalis pedis artery, and a left proximal anterior tibial artery pseudoaneurysm measuring 1.6 by 2 centimeters, which had grown significantly since the initial study, which showed a 5 by 8 millimeter anterior tibial artery pseudoaneurysm. The left anterior tibial artery aneurysm repair was done with a saphenous vein angioplasty and explantation of stent. During the procedure, below the knee trifurcation was visualized, which showed a left ATA takeoff with a large pseudoaneurysm. The tibioperineal trunk was patent but very small in caliber, while the perineal artery and the posterior tibial artery were very faintly visualized, and severe stenosis was seen in the posterior tibial artery and the proximal part. A left groin incision was made, and a left greater saphenous vein was harvested, and then the selective angiogram of the left distal popliteal artery, anterior tibial artery, and the tibioperineal trunk was done, and the morphology of the aneurysm was clearly delineated. Left lower extremity anterior compartment incision was made, revealing a sizable pseudoaneurysm and clot. The saphenous vein patch was fashioned to the defect, and anastomosis was completed. The patient was not a candidate for endovascular repair since earlier attempts were unsuccessful due to tracking issues, vessel tortuosity, and small caliber of the native anterior tibial artery. The patient made an excellent recovery and with resolution of both rest pain and ischemia. Thank you for listening to our presentation.